Hello, this is Sudharshan, and in this episode PA 24.6, we'll talk about inflammatory bowel disease. So there are two conditions in this, Crohn's disease and ulcerative colitis. So first we'll talk about the pathogenesis of the disease. So there are four important factors. One is genetic profile, second environmental factors, third deranged microbiota, and fourth immune dysregulation. So first we have genetic predisposition. So it is very common in those who are first degree relatives or have any HLA genes. Very commonly we can have B27, DR3 and DR4. Also CARD15 mutation, where mutation is there in chromosome 16q, 16q. Then environmental factors like addictions, alcohol, drugs, smoking, drugs very commonly NSAIDs and oral contraceptives, sometimes psychosocial factors like stress, depression, grief, sorrow, or any sad events, etc. And then deranged microbiota. So sometimes normal flora, when the infective dose is more, it will become pathogenic. There are some microbes, very commonly bacteria, like E. coli, Clostridia, Helicobacter. Rarely some viruses, protozoa, fungi also might be there. And then immune dysregulation. That is, there is defective balance between the helper and cytotoxic cells. So basically, it's an inflammatory state. So helper cells will release cytokines, interleukins, which will cause an inflammatory response, and it will try to damage the bowel wall. So these are the four important factors. Now we come to the disease. Crohn's disease and ulcerative colitis, we will compare. So Crohn's disease very commonly occurs in the terminal ileum and colon. Ulcerative colitis, as the name itself tells, inflammation of the colon, where ulcer is there, the slowing off of the mucosal layer. And then features of Crohn's disease, we will see now. Transmural inflammation, rectal sparing, skip lesions, granulomas, cobblestone mucosa. Then we can have perianal disease, fissures and fistulas also can be seen. Whereas if we see with the ulcerative colitis, here rectal involvement is there, pseudofibril polyps, crypt abscesses can be present. Yes, and with respect to the, and one more thing in ulcerative colitis, we can see the loss of haustral folds as well. So with the microscopic involvement, if we see, in case of Crohn's disease, we can see edema with exudative fluid. Granulomas are non-caseating, so they are not, tuberculoid condition is not seen. Whereas if we see ulcerative colitis, as I told in the features itself, the same thing, like crypt abscess, superficial ulceration, and ulcerative colitis is highly immunogenic. That means P. ANCA is positive. Complications very commonly seen in Crohn's disease, a very important one of which is erythema nodosum. Right, so when it comes to the diagnosis, so coming to the diagnosis, in Crohn's disease, we can have string sign on barium meal X-ray, whereas ulcerative colitis will show a lead pipe on barium meal X-ray. And when it comes to the treatment, ulcerative colitis surgery can be done, not for Crohn's disease, because Crohn's disease occurs anywhere in the body. So doing surgery is of no use. And apart from that, we can give antibiotics, corticosteroids to fight the infection. So that is all with inflammatory bowel disease. So thank you so much. I'll meet you in the next lesson.